for a patient, it typically depends on the relative urgency of that referral, on the degree of follow-up that I look at for that patient. So obviously with the full scope of practice that I do in Melfort, so I'm working in the emergency department of the clinic, my inpatients on the wards, I do a satellite clinic in another community. It's very different, the types of referrals that I need to make. So obviously your acute emergency referrals are going to be typically over the phone through ACAP, so that's direct. In my office practice, that's going to obviously be my electronic medical record. So if it's a relatively high urgency, I will note that on my referral that I'd like that to happen within a certain dedicated timeline, or note the urgency on that. I don't have control over the other side of it, so if it's a relatively urgent referral that needs to be seen, I will always advise my patients to follow up with me if they haven't heard from the specialist within what I tend to determine as a reasonable time. And I usually still have my pattern of referral to the docs that I refer to, so I know what their offices function like. So I usually know what's a reasonable turnaround time for them to hear back from those offices.
What are your recommendations for physicians making referrals so that they are also promoting better and safer primary care in their own practices?
Again, what my suggestion would be for the primary care physician making the referral. First of all, they need to have good referrals. You can't expect somebody to, provide good answers back on consultation letters if you're providing them garbage to start out with. And so I think there's, with the use of electronic medical records, there's no excuse why a referral can't be done very robustly with all the documentation needed. I think that's the primary thing. When you can do a referral now with all of your labs and ancillary documents, with a past medical history, medication list, everything within my EMR, I can do that within about a minute. There's no excuse not to make adequate letters. Now that requires you to have done your upstream work, which is filling in your EMRs properly. Obviously, if they're not filled in properly, then that's back to the drawing board and you have to do that. Otherwise, you're going to have a blank referral. So that's first and foremost. If we're asking specialists to help us, then we need to help them be able to provide the best care for our patients. The next thing is to build relationships with specialists. And so this is where I diverge from a lot of the direction of the province in that pooled referrals. I'm not a huge fan of pooled referrals. I feel like they take away that relationship that medicine is really built on in a lot of respects, where I have comfort with a specialist that I know, that I've learned from, or I've had dealings with before and I'm comfortable with that person, and I can confidently say to my patient, I would send my parent there, or I would go to them. And we lose that a little bit with pooled referral patterns. So building relationships, and the other flip side of that is the specialists get comfortable with you. So, I'll take for instance Dr. Cooper, the cardiologist in Saskatoon. He's a Melfort boy originally, so he knows our practice in Melfort. He respects when I phone him and I say, Kelly, something's just not right here. That's enough. I don't have to go further than that. He says, well, you don't have the test you need, send him in. And so it's those type of relationships that get your patients access to care earlier. And then obviously caring enough for those patients to recognize that just because you sent the referral doesn't mean that's the end of the story. If things are still happening in the interim, that door to your office needs to be open. If something changes in the interim, or they take a turn for the worse, that 2-week or that 4-week referral that you thought was adequate before may be a same-day referral needed now. And that's where you need to be willing to change and to roll with that and have access at your office. Because there's not just one solution to this. You need to be available for your patients if you're wanting them to get that access.